I would like to introduce Melanie Jansen. She's the co-lead of the working group to establish a Centre for the Children's Health, Ethics and Law at Queensland Children's Health. She's recently completed her Churchill Fellowship in Clinical Ethics and is currently working as a Senior Registrar at the Children's Health in Queensland.
Hi everybody, and thanks for that kind introduction. So I first started looking at the evidence for clinical ethics when we were putting together the business case to start our Centre for Children's Health, Ethics and Law at the new children's hospital that was being built several years ago in Queensland. And so we call our centre Seashell. And I then started looking at it again when at the first 2 years of our ethics services operation, we did an evaluation of the service. So I then started looking at quality indicators for clinical ethics and if there'd been any evidence emerging, any more empirical evidence emerging for their usefulness. So clinical ethics has been around, since at least the time of Hippocrates, but there is a growing recognition that there's increasing complexity in ethical decision-making now in healthcare, and that's partly because of intensive care medicine muddying the waters of things like the definition of death and terminal phases of illness. And there's a lot of new technology to deal with in technology-dependent children, but there's also been social changes with decreasing paternalism in the doctor-patient relationship and changing community expectations. So clinical ethics services have emerged as a resource to help clinicians and families navigate these more complex waters. Now, clinical ethics committees historically were generally convened ad hoc for difficult clinical cases. And what people usually meant when they said a difficult clinical case was a late termination of pregnancy or something else that was a bit legally grey, and the hospital wanted to show due process in what they were doing. And those early clinical ethics committees looked a little bit like this, where they would just convene a bunch of usually senior clinicians and they would make a substantive decision that would help the hospital build a case for any possible legal action. So things have changed a little bit since then, and it's a little bit different around the world. So in the US, it's been a largely legally driven thing, that there are some key legal cases in the late 70s and early 80s that led to a judge recommending that healthcare services should have clinical ethics services. And then it became an accreditation requirement for US hospitals in the early 90s. So as a result of that, nearly over 90% of hospitals in the US have clinical ethics services of some type. In the UK and Europe, it was more of a grassroots phenomenon that clinicians started noticing that they might need a bit more of a mechanism to deal with these problems. And it's variable, particularly across Europe. It changes between the countries are quite different, and even regions within different countries are quite different in how common clinical ethics services are. And the UK has a clinical ethics network that published a paper a few years ago saying that there were 80 clinical ethics committees in the UK. But I've had some personal correspondence since to say that perhaps that number has decreased a little bit in recent years. In Europe, they also have a European clinical ethics network, and while it's not an accreditation requirement for anyone in that region, they're working at developing clinical ethics services. One thing that the Europeans pay a lot of attention to, and what they're doing a lot of exciting research in, is they're looking very specifically at the types of deliberation that they use, and I'll come back a little bit more to that later. So in our region, it's been similar to the European and British story in that it's been more of a grassroots movement. It isn't an accreditation requirement for hospitals in Australia, but the Equip National Guidelines in 2012 recommend that there should be a mechanism for clinical ethics decisions, but they don't say what that mechanism should be. And in New Zealand, the Healthcare Quality and Safety Commission a few years ago recommended that a clinical ethics network be established and that there should be clinical ethics advisory groups in the different regions. And they've actually, to my knowledge, made some grant money available for that. So New Zealand are being a little bit more organised than we are about it. But this is also one area where paediatrics, at least in our region, is actually quite ahead of adult medicine. So the last survey that was done of general hospitals in Australia was pretty old, it's 2001, but it showed that only about 10% of general hospitals in Australia had a clinical ethics committee of some sort, and actually almost none of them did active case consultation. So we did a survey in 2017 of all the children's hospitals in our region, and we found that all except one had a clinical ethics service, and most of those clinical ethics services dealt with 11 to 15 case referrals per year. So Sometimes when I talk about clinical ethics services to clinicians, and certainly when we were doing the groundwork for setting ours up in Brisbane, I would get faces like this. And people would be like, really? Like, do we need another service? Haven't we been doing this for long enough? Can't we get the lawyers involved if we have a legal question? And look, I think people are right to be very wary of clinical ethics services. So people say, well, are they even useful? Do people use them when they're there? And this is very variable, but there is some evidence. For example, in the UK, a big survey was done of all their ethics centres a few years ago, and the vast majority of their ethics services dealt with less than 3 active clinical cases a year. People then say, are they even effective? Like, what are the outcomes? Are they affecting patient care in a positive way? My counter question to that is, what would even be meaningful outcome measures? And I'll come back again to that later. Another criticism that people say is, well, there's no professional standards for these people. Who are these clinical ethicists? There's no college for clinical ethicists. There's no particular qualification you have to have. It's kind of just seems like a bunch of people deciding that they're experts. And other people say, well, the clinical ethics services, maybe they are a bit helpful, but I don't think they're really doing anything different than what mediators do. They're really just doing conflict resolution, and can't we just call it what it is and get mediators in instead of having a whole new profession and service? So I'm going to let those criticisms hang there for a while I talk a bit more about the evidence, and I'll come back to them at the end. So when we were thinking about evaluating our service, we did want it to be a meaningful evaluation, and the questions we thought were, well, we can describe our service, and other services in Australia and elsewhere have described themselves before, but we thought maybe we could do a literature review and see if there are any emerging consensus standards for what we should be doing, and we could try and benchmark ourselves against those. We also wanted to know how active has our service been, how many cases have we done, and were the clinicians that referred to us satisfied with our service? And then we were also interested to know if we were having any effect on staff wellbeing. So with that, we structured the study into 3 sections. In the first section, we did a literature review to identify these standards, and then we looked at our service in relation to them and evaluated it. And then the second section, we reported our activity data, and in the third section, we reported results of feedback surveys that we sent out to clinicians. So in section 1, in our literature review, we identified 4 documents, one from the NH and MRC that was put out quite recently, one from the UK Clinical Ethics Network, and 2 from the States. And there was a huge amount of overlap in the recommendations that these papers made. And the key things were that they said, well, we don't have any evidence really to say exactly what people should be doing in this space. So at this point, it's actually more important that all the services are really transparent, that they have terms of reference and standard operating procedures and quality improvement things in place. So our service does have terms of reference and standard operating procedures, but when we looked in more detail at the things they said should be included in that, we realised that there are a few areas that we could make a bit clearer in our own operating procedures. There was another point of consensus where they said these services should be doing education, policy work and case consultation, and our service does all of those things. And in addition, we're starting out pursuing our own research agenda as well. There's a definite preference emerging for a multidisciplinary deliberative consultation model, and our service does have that type of model, but when we looked at it in more detail, we thought we are probably actually a bit doctor heavy. Our response pool of people is almost half doctors, and our core paid staff are mostly doctors. So we're addressing that by we put out a new expression of interest for more members, and we were trying to redress the balance and have fewer doctors as an overall proportion. And we're applying for funding to get a permanent nursing position as part of our service. There was also a big long list of staff knowledge and skill core competencies coming out of those documents, and our core staff do fulfil all of those, and our response pool members don't individually fill all of them, but as a group they add to our core knowledge base. The other thing that came out of these guidelines was that services need to be adequately funded. At the time of this study, we didn't have recurrent funding. We were funded for a 3-year period through charity funding, but I'm pleased to say that we have, just in the last couple of months, secured core hospital ongoing funding. So our service, I'll just quickly describe. We've got a 0.2 SMO clinical lead and a 0.5 fellow position and a 0.2 admin officer. And that's our response pool at the time of the end of this study. There were 44 members, and that was the breakdown. So what happens when you refer a case to us? I hope that you can read those little boxes, but Just to talk through quickly how we work, a clinical team will come across a case that they're concerned about and they phone the clinical ethics fellow for a referral, and after talking to them, the clinical ethics fellow will decide whether this response needs a level 1 response or a level 2 response. And a level 1 response is simply attendance by the fellow or the consultant at a multidisciplinary team meeting for this case, and they can be a part of the conversation there and maybe help clarify some ethical issues, and sometimes that's all that's required. A level 2 response is a more formal clinical ethics consultation service deliberation, we call it, and it is essentially the same as an MDT, so all the people that would be at an MDT come along, but the meeting is chaired by the ethics fellow or the consultant, and we bring along an ethics response team from our response pool members. And our terms of reference say that we have to have at least 3 people from the ethics team that aren't clinically involved with the case come along to that deliberation. So in our deliberation, it takes about an hour, and we have a structured way that we deliberate. So we first identify the ethical question that we're trying to answer. We have a summary of the medical issues and facts, so everybody's up to date with that. We then explore the narratives of the family and all the clinical staff that are involved, and then we have a period of time where we identify the ethical principles and values that are at stake, and we identify possible ways forward, and then go through a philosophical process where we weigh up the ethical rationale for each of those. And we come up at the end of that hour or sometimes hour and a half with a plan that has been collaboratively arrived at by the clinical multidisciplinary team and the ethics response group. The ethics fellow then writes a summary of that up. It's usually about 2 pages, so it's a detailed summary of the rationale for the plan. It's sent out to all the people that are at the meeting, and they all have to check that it's reflective of the discussion. And once everyone's happy, it's turned into a PDF, put into the medical record, and a copy given to the parents. We then send out a survey to all the clinicians to ask how we performed in that referral, and then we discuss those cases at our quarterly review meeting. So section 2, our service activity. So how much of this did we actually do? So in the first 2 years, we did 10 level 1 responses and 14 level 2 responses, and 2 of those level 1 responses were escalated up to level 2s. 17 specialties were involved. Unsurprisingly, I guess the most common was general paediatrics, followed by palliative care, followed by PICU. And in addition to our case consultation work, we also delivered 35 education sessions in that first 2 years. So in section 3, for the feedback survey results, we had a response rate of 36%. The people who responded were mostly SMOs, followed by nurses, allied healthcare, advanced trainee registrars and social workers. And we did get some useful information out of this survey for our own service improvement. So people reported that they thought our processes were efficient, they thought that we understood the issues. All bar one respondent found the process helpful, and everybody, including that respondent, said they would consider recommending us to colleagues. So that was useful for us, but the most interesting finding for me, and what I think will be most interesting to other people, is that 80% of the survey respondents reported that involving the clinical ethics consultation service had at least somewhat decreased their own moral distress. Of the 20% that reported no decrease in moral distress, no one reported increased. The majority of those people, so there were 7 people that reported that they didn't have decreased moral distress, and 6 of those were SMOs. However, still 10 of the 16 SMOs that answered the survey said that it did decrease their moral distress. And I think this is an interesting finding because, as we've all heard, I know in Fiona's talk earlier in the conference, is that moral distress is a key factor in burnout of physicians, and it's particularly noted in ICU. So just to discuss the limitations of our study. So the first section, the evaluation against external standards. I think this was a good exercise for us to go through, and we noticed deficits in our service that I don't think we would have noticed if we hadn't looked to an outside benchmark. And I think we wanted to set an example that this is what other clinical ethics services should be doing instead of just describing what they do. They should be trying to see if they're measuring up to these standards. But I think self-evaluation always has to be obviously interpreted with caution. In terms of our service activity, this is also helpful data because it helps build a contemporaneous picture of what clinical ethics services are doing and how active they are. And it encourages transparency and at least allows you to compare yourself to other services. And from doing that, we know that we're about equal to the US average. There was a big survey done by a group in Boston of lots of children's hospitals in the US. And based on the activity that they reported, we're doing about as much on average as they are. And we know that we're one of the 3 most active in Australia from our survey study that we did last year. But again, I think service activity data is kind of interesting, but in terms of a quality marker, I think it needs to be interpreted with caution. I think you could interpret high clinical ethics service activity as just being reflective of a service existing in a really defensive culture, or it could be that you're not doing very much education and capacity building and the clinical teams are becoming dependent on you for every little decision. By the same token, a lower activity might represent that you've got good capacity building programs in place, but at the same time, if no one's ever using you, it probably reflects that they don't think that you're useful. And then feedback surveys, I think in principle, need to be interpreted with caution as a quality indicator for clinical ethics overall, because while I was happy that the clinical staff that use the service were satisfied with it, and I was particularly happy that it seemed to decrease their moral distress, it's only one marker of quality for a clinical ethics consultation, and clinician satisfaction is probably necessary but not sufficient for a good clinical ethics consult, because it may just reflect that we're delivering outcomes that are pleasing to clinicians. And I would in the future like to do more work and survey the patients and families that have been involved and see what they think. We also had quite a low response rate, which was disappointing, and I think there are a couple of reasons for that. I think the first and main one is that people are just completely overfilling out surveys because everyone has to do quality improvement, and surveys are a very easy thing to do for that. But the other thing that I heard anecdotally from some of the clinicians was that sometimes a whole team would come, so a consultant, registrar and resident, for example, and the consultant would fill out the survey on behalf of the whole team, so I think we lost some responses in that way. So the other major limitation of data like this is that it is just descriptive, and we're not testing clinical ethics as an intervention. And there is a little bit of interventional evidence in the clinical ethics space coming out, and one of the studies that I think is the best was this multi-centre RCT done in adult ICU in the States. It was published in JAMA in 2003, and actually randomised people to be offered a clinical ethics consult or not. The patients were identified by a nurse that rounded and identified patients that had existing or likely conflict in their case, and then they were randomised to get offered a consult or not get offered a consult. The outcomes that they looked at were hospital and ICU length of stay and the length of life-sustaining therapy in people that didn't survive to discharge. So the data analysis was done on an intention to treat basis, and there was a decent amount of crossover between the groups. But the findings were really interesting. So they found that amongst people who didn't survive hospital discharge, people who'd had a clinical ethics consult had almost 3 days shorter hospital length of stay, almost 1.5 days less in ICU, and 1.7 days less ventilation. So some people read this study and go, oh, the clinical ethics service is killing off patients, but it's not. There was no difference in mortality between the group that did survive to hospital discharge that were or weren't offered a clinical ethics consult. But it looks like in those that were going to die anyway, the clinical ethics consult shortened the amount of inappropriate therapy that they got. So in terms of other RCTs, that group did a pilot study before they did that had similar findings, and there's been one single centre RCT of a similar nature done in Taiwan that showed similar findings. In terms of other evidence in this space, there was actually a bioethics journal special edition in 2017 devoted to quality and clinical ethics services, and there was so little evidence that they actually had trouble cobbling together one issue. So that is a big problem in this space. But some of the interesting stuff that came out in that issue is that the Europeans, and this is mostly based in Amsterdam, they have defined domains of quality for deliberations. They can say, we can tell if we've had a quality deliberation, and they've developed a coding tool for this, and they've validated that, and now they're going to start evaluating their deliberations based on that. And I think this is really exciting and meaningful quality work in this space, and I'm looking forward to seeing what else this group end up doing. So in terms of future research, I think there's obviously a huge amount to do in this space because I think we need to make sure that what we're doing in clinical ethics is meaningful and rigorous and is making a difference. And I think there's a lot of conceptual work to do, so we need to define things like ethics expertise. What does that even mean? We need to define what are our quality domains for clinical ethics service provision. And I think there's empirical work that needs to be done. I'd be interested to see what this audience thinks of the idea of a randomised controlled trial of paediatric clinical ethics consultations. I think we need to continue building those tools to evaluate our deliberation methods. And I think a really interesting area of research will be to further explore the wellbeing role of clinical ethics services. Obviously, the data from this study is purely hypothesis generating, and we need to really explore that and see how we can harness that. See if it's real first and see if we can harness it if it is. Thanks.
Thank you, Melanie. We probably have time for one question.
Thank you. It was really very interesting. I'm Fenella Gill from Perth Children's Hospital, and I'm a member of our clinical ethics committee, so I was really interested to hear your presentation. It sounds as if your service is very medical-centric, and I guess that's something that we are a little bit different. We have some referrals from parents and promoting referrals from others who work in the health service. So I wondered whether you could comment on that.
So in our terms of reference, anyone who's clinically involved with the patient can refer to clinical ethics, so it doesn't have to be the lead clinician. In practice, the lead clinician so far has always been happy with that, but that was one thing that we wanted to put in place, because we know that sometimes ethical issues are that other staff members don't agree with the lead medical team's treatment, and that's a source of moral distress, and that's where we want to be notified. So you don't have to be the lead consultant to make a referral.
Thank you, Melanie.